Welcome everyone to the Health for the World International Grand Rounds. Our Grand Rounds speaker today is Dr. Virginia Hill from Northwestern University. I'm really excited for these Grand Rounds. And I know Dr. Hill for a long time. She's an excellent speaker and a very renowned neuroradiologist and a really good human being. Dr. Hill Dr. Hill did her medical school at Loyola University and her residency at John Stroger Cook County Hospital, where she was a chief medical resident. She also did her fellowship at University of Cincinnati, where I met her, and I've been really impressed by, her really wide, expansive knowledge. This is one of her favorite topics, and I really look forward to this. So thank you so much, Dr. Virginia Hill, for doing this for us. And you can start whenever you're ready.
Thank you. Thank you so much for inviting me. This is just a wonderful group and a great opportunity. So thank you. So today we're going to talk about intraaxial brain tumors. Oh, can I not advance my slide? Hold on. There we go. So we'll start at the beginning. Some basic things, and then we'll get into some more advanced things, especially about the molecular markers involved with brain tumors that have become so important to determining the prognosis of the brain tumor and how it can be treated. So the first thing to differentiate is whether the tumor is intraaxial or extraaxial. So extraaxial tumors can be intradural, where they will buckle the white matter, expand the ipsilateral subarachnoid space, and can cause reactive bony changes. And then also there are extradural brain tumors that can displace the dura inward, for example, bone metastases. Intraaxial tumors, on the other hand, tend to expand the cortex of the brain. There is no expansion of the subarachnoid space. They spread across well-defined boundaries. The dura and the peel blood vessels are peripheral to the mass, and the intraaxial lesion may invade the meninges, like lymphoma or glioblastoma or parenchymal metastases, for example. So sometimes it can be a little bit difficult to tell the difference between an intraaxial and extraaxial tumor. In 2016, the WHO, the World Health Organization, reclassified brain tumors and really rocked the neuroradiology and neuropathology worlds. They incorporated genomic biomarkers into an integrated diagnosis. So now, instead of simply depending upon the histology of the biopsy or resection sample, they integrated the molecular and genetic information that they can determine through doing various tests. This allowed greater diagnostic precision and lower variability, and also allowed greater clinical relevance and predictive value. The 2016 article that described this classification is in Acta Neuropathology, and this is one of the, I'm sure you've seen this before probably, it is a chart that basically explains in that 2016 work how they differentiated these different types. So previously, we sometimes had a category called Oligoastrocytoma that really no longer exists. Now everything is either, in terms of gliomas, astrocytoma, oligodendroglioma, or glioblastoma, and you can determine what they are by looking at this IDH mutant or IDH wild type designation, which we will talk about further in just a moment. So IDH mutant tumors, if they have ATRX loss, which we're also going to talk about, or TP53 mutation, they are a diffuse astrocytoma IDH mutant. If they are 1p19q co-deleted, they are an oligodendroglioma. And then IDH wild type tumors become diffuse astrocytomas, or used to be oligodendrogliomas, maybe now not quite so much, and we'll talk about that too. There have been some updates over the years. Then glioblastomas. In this chart, there are IDH mutant glioblastomas, but as we'll talk about in a few minutes, this is really no longer the case. There are IDH wild type glioblastomas. Now, not all IDH wild type tumors are glioblastomas. Some of them will be a lower grade than a grade 4, but there are no longer any IDH mutant glioblastomas. So let's talk about IDH first. So IDH is isocitrate dehydrogenase, which converts alpha-ketoglutarate to 2-HG. You may remember from studying the Krebs cycle in medical school, which I know is a long time ago, but very important still. So 2-HG is an oncometabolite, and superphysiologic levels of it will inhibit DNA repair and other enzymes. This alters the cellular epigenetic profile and makes the cells prone to other mutations, including 1p19q co-deletion. It induces broad metabolic reprogramming, inhibits cellular differentiation, and therefore causes cells in the frontal horns of the lateral ventricles to be maintained in a stem cell-like state and more prone to tumorigenesis. So IDH mutant tumors, on the other hand, the mutant protein is D2HG, and it causes non-neoplastic reactive astrocytosis. So IDH wild-type tumors have a poor prognosis, and IDH mutant tumors have a better prognosis. The WHO grading pretty much still, however, stayed very similar to what it was before 2016. So grade 1 tumors, and notice that I'm using Roman or Arabic numerals here instead of Roman numerals, and this we'll talk about in a second too, with some updates that have occurred since 2016. So grade 1 tumors are pilocytic astrocytomas, diffuse neuroendocrine gangliocytoma, ganglioglioma, Lhermitte de Clos, DIGs, and Medulloblastoma. Grade 2 tumors are diffuse astrocytomas, oligodendrogliomas, pleomorphic xanthoastrocytomas, and ependymomas, although some ependymomas can be higher grade. Grade 3 are anaplastic tumors, grade 4, glioblastomas, and embryonal tumors, the most famous probably of which is the medulloblastoma. So CIMPACT-NOW is this group that is basically a consortium to advise the WHO. So whereas the WHO meets every 9 to 10 years, our scientific advances are occurring way faster than that. So we needed some sort of organization to give updates and guidance more often to keep up with brain tumor research and to address questions that people had and practice gaps. This was formed in 2017, and so far there have been 7 updates, the latest one of which appeared earlier this month. So some of the more important updates. Update 3 indicated that the large majority of IDH wild-type diffusely infiltrative gliomas that would be considered histologic grade 2 or 3 have genetic alterations and aggressive clinical behavior similar to glioblastomas, WHO grade 4. Not all IDH wild-type gliomas are molecular glioblastomas, and those IDH wild-type tumors that have EGFR amplification, which is epidural growth factor receptor, it promotes cell growth and division, chromosome 7 gain and chromosome 10 loss, which also affect the cell cycle and division, and TERT promoter mutations, which allows an abnormal activation of telomerase, which will allow the cells to live longer and not go through apoptosis. So IDH mutant astrocytomas are now classified in 3 ways. IDH mutant astrocytomas that are grade 2 are well differentiated with no or low mitotic activity. IDH mutant astrocytomas that are grade 3 have anaplasia and mitotic activity. Astrocytomas IDH mutated that are grade 4 have microvascular proliferation or necrosis or CDKN2A and B homozygous deletion. And the CDKN2A and B also affects the cell cycle. So glioblastoma, that term is reserved for IDH wild-type grade 4 tumors. And oligodendrogliomas are 1p19q co-deleted. In oligodendrogliomas, generally ATRX is intact. Alpha thalassemia mental retardation X-linked gene is the long name for ATRX. It codes the telomere binding protein, and the mutation allows alternative lengthening of telomeres, which again allows the cell to escape senescence and to continue to grow and divide. ATRX is retained in oligodendrogliomas but lost in diffuse astrocytomas and anaplastic astrocytomas. So let's get into the fun part, which is looking at images. So diffuse astrocytomas are infiltrating and ill-defined, no enhancement or hemorrhage. They are hypodense on CT, T1 hypointense, and T2 hyperintense. And here is an example. This is a diffusion-weighted image. So on the left here we have the DWI, on the right we have the ADC. We can see there's no restricted diffusion. On T2 and FLAIR, the tumor is bright. It's involving the cortex and subcortical matter, and there is really no enhancement. And this is a diffuse astrocytoma. Then we also have these diffuse midline gliomas that we used to think were a lower grade than what they really have turned out to be. So they often occur in children, but they can also occur in elderly folks like 70 or 80 years old. And in 2016, the WHO included the H3K27M mutation of the diffuse midline glioma. So this category includes tumors previously called diffuse intrinsic pontine glioma, or DIPG. They occur in the midline, for example, of the thalamus, brainstem, spinal cord, and cerebellum, and hypothalamus too. They are high signal on T2 and FLAIR images. They may subtly enhance on MRI. They tend to encircle the basilar artery. Approximately 60% of them have this H3K27M mutation, which confers a poor prognosis and is really a high-grade glioma, despite the subtle or no enhancement on MRI. They tend to occur in children who are 1 to 10 years old in age. And also, though, not to forget, they occur in elderly adults as well. So this H3 is basically an indicator of a histone mutation. So this is a histone mutation, and we have to think back to cell biology and what we went through in med school and undergrad. What is a histone? Highly alkaline protein found in eukaryotic cell nuclei that package and order DNA into structural units, such as chromatin. So H3K27M mutation is found in a diffuse midline glioma, but it can also occur in other tumors too, and it's important to only use this diffuse glioma designation, diffuse midline glioma designation, for tumors that are really in the midline. So it will occur in other tumors, and they are not considered to be diffuse midline gliomas. The mutation can occur on H3.3 or H3.1. H3.1 confers a slightly better prognosis than H3.3. And then we're not going to talk too much about this, but there is also this H3G34R or V mutation tumor, which is also a glioma that will occur supratentorially, often in more adolescent patients. So here we have a coronal FLAIR image, an axial FLAIR image, axial T2, sagittal T1 without contrast, sagittal T1 with contrast and fat saturation, and axial T1 with contrast and fat saturation. And we can see that we have this expansile T2 and FLAIR hyperintense mass that is encircling the basilar artery, creating quite a bit of mass effect. It does not have much of any enhancement at all. And this is a diffuse midline glioma. Other lesions that can expand the brainstem that are important to keep in mind for your differential diagnosis are TB, lymphoma, rhombic encephalitis caused by listeria, and demyelinating disorders such as ADEM and MS, and osmotic demyelination. Diffuse anaplastic astrocytomas are mostly IDH mutants. In fact, we'll just say, since the CIMPACT-NOW updates, they're IDH mutants. 4th and 5th decades of life, T2 hyperintense lesions, no necrosis or hemorrhage. Most of them enhance. They can be focal and irregular. The prognostic differences between IDH mutant diffuse astrocytomas and IDH mutant anaplastic astrocytomas are not as marked. And here we have a T1 weighted image. You can see it's a little bit of a heterogeneous tumor. On our FLAIR, we have a bit of heterogeneous T2 and FLAIR hyperintensity. And then we have this cystic appearing or necrotic appearing mass with this enhancement around it. It's sort of multifocal, and this turned out to be an anaplastic astrocytoma. Now, could this have been a glioblastoma? By imaging, it could have been. So there are some overlaps in the appearance. The glioblastomas are the most common astrocytoma, unfortunately. They demonstrate necrosis and ring enhancement, but they can also be solid. They have mass effect, often have hemorrhage, daughter and satellite lesions. They cross the corpus callosum, anterior commissure or posterior commissure. They lead to subarachnoid seeding, and they can coat the ventricles. The surrounding T2 FLAIR signal around the enhancing portion of the tumor includes infiltrative non-enhancing tumor. So you cannot just call the FLAIR hyperintensity around the tumor edema, because part of it is going to be tumor. So saying something such as peritumoral white matter in your report may be a more accurate way to describe it. So IDH wild type glioblastomas occur usually in people over 55 years old, but not always, and they confer a very poor prognosis. The survival is on average 15 months after this diagnosis. IDH mutant tumors are no longer glioblastomas. They would then be astrocytomas grade 4. IDH mutant tumors tend to be about 10% of the cases and occur in younger patients. But remember, no more IDH mutant glioblastomas. Here's an example of a CT. We can see this heterogeneous tumor with some CT hyperdensity. And on T1 axial contrast enhanced imaging, we have this very heterogeneously enhancing tumor involving the corpus callosum with necrosis. On FLAIR images, we have this fairly heterogeneous but still predominantly FLAIR hyperintense lesion. Notice how on the T2 weighted image, the T2 signal is slightly what we call dirty, a little bit dark, indicating increased cellularity. And then again, on our contrast enhanced T1, we have this heterogeneous enhancement with necrosis, and this is a glioblastoma. Now, glioblastomas, as they undergo treatment and are followed over time with MR, it can be very difficult to determine whether what we're looking at is treatment effect or is actually true growth of the tumor. It's a real conundrum in neuroradiology. And one of the tools we have to help us with that, to determine if it's progressing or not, is this updated RANO criteria, which is the response assessment in neurooncology. So we have these categories of complete response, partial response, stable disease, or progression of disease. So for progression of disease, any one of these categories, if it's positive, will indicate progression of disease. So if you measure the enhancing tumor in 2 dimensions, so not 3 dimensions, but 2, such as on an axial image, for example, and the area is increasing by 25% or greater, that would indicate progression. If you have increase in T2 and FLAIR signal, that would indicate progression. If there is a new lesion, that would indicate progression. Whether the patient is on corticosteroids or not, for this particular category does not matter. And then if the clinical status is declining, then that would indicate progression. For these other categories, we have to have all of these criteria fulfilled. So we would love to see complete response. We really almost never do. For complete response, you would have to have no gadolinium enhancing disease any longer. The T2 and FLAIR signal would have to be stable or decreased. There can be no new lesions. The patient cannot be on corticosteroids, and the clinical status has to be stable or increasing. For partial response, you would have to see more than 50% or at least 50% decrease in the size of the tumor as measured in 2 dimensions. You would have to see stable or decreasing T2 and FLAIR signal. There would be no new lesions. The corticosteroid use would be stable or decreasing, and the clinical status would be stable or improving. For stable disease, that would be everything else. So between, it's declined in size, but not by 50%, or it's increased in size, but not by 25%, stable or decreasing T2 and FLAIR signal, no new lesions, stable or decreasing corticosteroids, and stable or increasing clinical status. So post-treatment glioblastomas, if it is not true progression of disease, it could be pseudoprogression or radiation necrosis, which we will talk about in detail in a moment. But with certain medications, such as bevacizumab, that the patient may be receiving, they could have a pseudo-response. And it's important to remember that the enhancement by itself is not a measure of the tumor response or progression. It simply reflects a disturbance of the blood-brain barrier. So for radiation changes, such as pseudoprogression, this will occur several weeks to up to 3 to 7 months after radiation therapy. It means that there is oligodendrocyte injury that transiently impedes myelin synthesis. Radiation necrosis will occur months to several years after radiation therapy. There will be endothelial apoptosis, small vessel permeability and edema, and blood-brain barrier permeability, and a space-occupying necrotic lesion with mass effect and even a neurodeficit can occur. For pseudoprogression, we have MGMT promoter methylation often, not always, but often. And what is MGMT? It is a methylguanine methyltransferase that is involved in DNA repair and silenced by promoter methylation. It occurs with or without clinical deterioration, but usually the patient is asymptomatic. You can have lots of inflammation, edema, abnormal vessel permeability. It looks really bad, but maybe it isn't. And we'll talk about how to differentiate that in a second. Pseudoprogression is more frequent after temozolomide and radiation therapy, and also after temozolomide and radiation therapy can be an indicator that the treatment is working well. Sometimes that inflammation is really good. It allows the chemotherapy to get into the tumor and really attack it. So here we have a picture from a famous article from AJNR in 2011 that is in the references, where we see post-biopsy, you see this enhancing tumor and T2 signal around it. After surgery, you can see that, maybe a little more nodular. 1 month after surgery, still doesn't look like it's getting smaller, and the T2 signal is getting maybe a little bit more extensive. At 3 months, it's still there, still worrisome, very heterogeneous. It looks very similar to a glioblastoma. Our T2 and flare signal is still pretty worrisome. There was a biopsy done at this point in time. It was negative. This was pseudoprogression. And you see at 6 months and 12 months, the tumor is getting smaller. And the flare signal and T2 signal is getting better. So pseudoresponse occurs after receiving bevacizumab, which is an anti-VEGF antibody. You will see normalization of the blood-brain barrier. Though there's decreased enhancement, there may be increased flare signal. The DWI will show restricted diffusion, and this can predict the enhancing tumor to come later after the patient is off of bevacizumab, or even sometimes while they are still on it. You will have increased cellularity and relative tumor ischemia. There can be symptom improvements, reduction of steroid dependence, improved quality of life, even with true progression. So the patient may feel a whole lot better, but that tumor in the background is becoming more infiltrative and expanding. And that leads us to another infiltrative expansive pattern. It used to be considered an entity, and it no longer is. Now it is considered to be an imaging pattern, this idea of gliomatosis cerebri. This occurs in IDH mutant astrocytic and oligodendroglial tumors, and also in IDH wild-type glioblastomas. I have seen a number of very high-grade, aggressive, terrible tumors that really started as gliomatosis cerebri. So it's important to really think of these as a potentially extremely aggressive tumor. This tumor is widespread, involves 3 cerebral lobes or more, often bilateral, and may involve the cortex, deep gray matter, brainstem, and cerebellum and spinal cord. On CT, you will see loss of gray-white differentiation and subtle mass effect, and on T2, you will see diffusely increased signal. It involves the gray and white matter, and there is minimal, if any, enhancement. And here is an example. We see this mass-like, confluent, multi-spatial tumor, and this is a gliomatosis cerebri pattern. Oligodendrogliomas are 1p19q co-deleted, ATRX intact. And keep in mind, this ATRX deals with the senescence of a cell. So when we have loss of the ATRX, that is a little bit of a worse prognosis. So this 1p19q and IDH mutated tumor with ATRX intact means that this is going to behave less aggressively. Oligodendrogliomas involve the cortex and subcortical white matter. You can have calcification, soft tissue, and cysts that can be somewhat heterogeneous. It is a poorly circumscribed tumor. You will have variable enhancement in 50 to 67% of the tumors. You can have hemorrhage and peritumoral edema, but it's pretty uncommon. And you can have T1 hypointense and T2 flare hyperintense signal. On CT, hypodense or isodense, the skull may be thinned or remodeled, there is no edema, and you can unfortunately have subarachnoid seeding. Pediatric oligodendrogliomas are histologically similar to adult tumors, but often have no IDH mutation or 1p19q codeletion. And here's an example, albeit motion degraded, of an oligodendroglioma. Note it's cortical and subcortical. It has very poorly defined margins. There's really not much edema around it and no enhancement. So this is oligodendroglioma. Now, as it increases in grade with anaplasia pathologically, it becomes an anaplastic oligodendroglioma. When hemorrhage and necrosis, calcification, and cystic degeneration and avid enhancement become much more likely. And here we have a CT. We can see this calcification in the tumor. We can see a heterogeneous cystic and solid appearance of the tumor. It has some enhancement, and this is an anaplastic oligodendroglioma. Other astrocytic tumors that are important to know about: pilocytic astrocytoma, formerly called juvenile pilocytic astrocytoma. 60% occur in the cerebellum. Rarely you can see it in the cerebral cortex. It tends to be a cyst with a nodule, but the example I'm going to show you in a minute, it doesn't always have that very classic big cyst with a eccentric enhancing mural nodule. Sometimes it looks a little bit different. It also can be infiltrating. It can appear in the optic nerve or chiasm as a third ventricle or tectum and be solid and infiltrating. It is a relatively benign tumor. It's WHO grade 1. It can be cystic with less anaplasia. Tends to occur in younger patients where it is more likely cystic, and it is associated with a BRAF fusion alteration genetically. The BRAF alterations tend to occur in cystic lesions. The BRAF refers to the MAPK kinase pathway, which is an oncogenic pathway that you may remember from biochemistry or cell biology. So here we have an axial T2 weighted image with this bright tumor that's a little bit heterogeneous, and we can see that it's also bright on flare. On our T1 contrast enhanced images, the little neural nodule for this particular case is actually very, very small and not exactly what you would typically expect for this tumor that you've probably seen already in textbooks. So it's important to remember that that appearance may not be, a huge cyst with a really well-defined big nodule. Pleomorphic Xanthoastrocytomas occur in kids and young adults in the first 3 decades of life. They can occur at the periphery of the temporal lobes and other places. They cause seizures. There's homogeneous enhancement of a cortical mass. The cyst and nodule or solid mass with internal cysts can manifest as the appearance. There will be no hemorrhage. It can be very difficult to distinguish it from a dysembryoplastic neuroepithelial tumor, but it does enhance more frequently than those. There will be a dural tail, but no cortical dysplasia. It's WHO grade 2, and it is associated with a BRAF V600E mutation with CDKN2A and B homozygous deletion. And this, the cyclin-dependent kinase designation, is basically a controller of the cell cycle. So here we have a T2 weighted image, and we see this little cystic tumor over here in the temporal lobe. It's a little flare hyperintense and T2 hyperintense. It has maybe minimal enhancement here. You can see this little bit of enhancement, and this is a PXA. Ependymomas. Most ependymomas are infratentorial in the fourth ventricle and in the spine, but 30 to 40% of them are supratentorial, often parenchymal, and can be large and bulky. They can have cysts and calcifications and hemorrhage. CT will show mixed density, T1 hypointensity, and T2 hyperintensity. Infratentorial ependymomas arise from the floor of the fourth ventricle and insinuate through the foramina. You can have hydrocephalus due to blockage of the fourth ventricular outflow, and these tumors can be associated with NF2. They have a high incidence of subarachnoid seeding, and because of that, it's important to image the entire neuroaxis. There are 9 subtypes, again, based on this radiomic molecular classification. There are 3 subtypes each in the supratentorial, posterior fossa, and spine spaces. For each of these, a subependymoma will be the lowest grade, and it occurs in all 3 of these spaces. All of this is detailed in the CIMPACT-NOW Update 7. The supratentorial relofusion lesion is the one with the poorest prognosis that occurs in all ages. Also, posterior fossa type A has an exceptionally poor prognosis and occurs in babies and children. And posterior fossa type B has a better prognosis and occurs in kids, adolescents, and adults. So here we have a pretty classic appearance for the fourth ventricular tumor. So on CT, we see this heterogeneous lesion with calcification. On contrast enhanced MRI, you can see this heterogeneously enhancing tumor that is a little bit bright on flare and T2. So that leads us into the neuronal, mixed neuronal and glial tumors, which include gangliocytoma, gangliogliomas, desmoplastic infantile astrocytomas, DNETs, neurocytomas, and some others that are less common. It's important to remember cystic tumors often involve BRAF alterations. So gangliogliomas occur in kids and young adults. They're the most common mixed glial neural tumors of the CNS. They cause seizures. They're cortical, benign, slow growing. They cause bony remodeling. They can be cystic with a mural nodule or solid. They are T1 hypointense and T2 hyperintense. 70% occur in the temporal lobes, 10% in the frontal lobes. 50% of them will enhance. And on FDG PET or thallium 201 SPECT, you can have some low uptake, and you can also have associated cortical dysplasia. And here's an example of a T1 hypointense, T2 hyperintense cystic tumor with some enhancement, pretty avid in this case, and that is a ganglioglioma. So as we've already talked about pleomorphic xanthoastrocytoma, which look very similar, some ways to differentiate are that the PXA can have a dural tail with an enhancing nodule that abuts the peel surface. The DNET can have more of a bubbly appearance with T2 hyperintensity with rare mild enhancement and may remodel the calvarium. Pilocytic astrocytomas can also have a supratentorial location, are typically solid and cystic or solid with enhancement and no calcification. Low-grade astrocytomas often have no enhancement. Oligodendrogliomas can be calcified with heterogeneous, more diffuse enhancement than ganglioglioma and may remodel or erode the calvarium. Gangliocytomas have no glial component and no malignant degeneration. They involve the cerebral cortex, mostly in the temporal lobe. There can be adjacent cortical dysplasia. In the cerebellum, this is what constitutes Lermite-Duclos disease. CT will show mixed density, cystic and solid appearance with calcification, no blood or necrosis. They are hypointense on T1, hyperintense on T2, and flare with variable enhancement. And Lermite-Duclos is basically a dysplastic cerebellar gangliocytoma with a diffusely infiltrated mass-like lesion in the cerebellum, WHO grade 1. It involves the gray and white matter. It has a T2 hyperintense tiger stripe appearance, and there will be abnormal veins around the thickened folia. You can have increased FDG uptake, relative cerebral blood volume, and diffusion restriction in these tumors. They occur in people in their early 20s, and they can cause increased intracranial pressure or ataxia. And here is an example of Lermite-Duclos with this tiger stripe appearance of the cerebellum involving the cerebellar folia, gray and white matter, with very little enhancement, but you can see abnormal veins within this plastic folia, and that is Lermite-Duclos. Dysembryoplastic neuroepithelial tumors are cortical, often with cortical dysplasia. 50% occur in the temporal lobes and 30% in the frontal lobes. They can cause seizures. They can look like a ganglioglioma. They occur in the second to third decade of life in patients with chronic seizures. They are peripheral, always involve the cortex, often involve subcortical white matter leading to a wedge-shaped or triangular abnormality because they're traveling along radioglial fibers. They are bubbly, CT hypodense, T2 hyperintense with calcification with blooming. Less than a third will enhance, which differentiates them from desmoplastic infantile ganglioglioma. They can have variable mass effect and no edema, and they are associated, again, with a lot of cystic tumors with a BRAF mutation. And here we have our little T2 hyperintense tumor, which is, it suppresses on flare and is dark on T1. And here's another one, suppresses on flare, dark on T1, not much enhancement, T2 hyperintense, and that was a DNET. Embryonal tumors include neuroblastoma. They have restricted diffusion. They're not T2 hyperintense as much because they're highly cellular. They tend to be dense on CT. There's not much edema. You do have a lot of subarachnoid seeding, so you have to image the entire neuroaxis. They can be heterogeneous with bleeding, but less so in children, and they tend to be well circumscribed. They are WHO grade 4, and actually I should have changed this to an Arabic numeral now, because in the CIMPACT-NOW, they find it clearer to use Arabic numerals instead of Roman numerals. This is involved with upregulation of oncogenic mRNA cluster C19MC on chromosome 19. The old term PMET is no longer in use. With methylomic profiling, we now have better classified these tumors, and these are considered to be embryonal tumors. Medulloblastomas are embryonal tumors, and probably the most famous or well-known of them. And atypical teratoid rhabdoid tumors also are embryonal tumors. So medulloblastomas I find to be fascinating, and you could do a whole lecture only on medulloblastomas. So we're going to have to be a little bit quick about this description. But they have 4 basic classes. WNT activated, which really tend to be brainstem tumors. So you can see them in the brainstem or in the middle cerebellar peduncle sometimes. They are the lowest risk tumors. This is the kind you want to have if you have to have a medulloblastoma. Then there's the SHH activated or sonic hedgehog tumors, which are subclassified according to whether they have a TP53 mutation or not, with a higher risk if they do have the mutation. These tend to be more lateral cerebellar tumors, but not always. And also, when we're talking about medulloblastomas, of course, they are a very well-known pediatric tumor. When they occur in adults, most of them tend to be the sonic hedgehog activated tumor. And then we have group 3 and group 4, which are non-Wnt SHH tumors. And they have standard risk. Group 4 is particularly problematic because it often does not enhance. And really any of these, the enhancement can be variable. They may not enhance. It makes it very difficult sometimes to detect them. And also when you're looking for their metastases, it makes it difficult to detect those as well. The classic medulloblastoma occurs in the midline fourth ventricle and infiltrates the dorsal brainstem. There is necrosis and hemorrhage, cysts, calcification. They can be highly cellular, really are highly cellular, not can be, are. Hyperdense on CT, hypointense on T1, hyperintense on T2. There's variable enhancements. You can have peritumoral edema in about a third, and 50% will have CSF dissemination at diagnosis. So it is very important to image the entire neuroaxis. And also when they recur, they may recur more often distant from the initial site where they arose in the posterior fossa. So that is also pretty scary and something to keep in mind. As you follow them, you have to image the entire neuroaxis. To differentiate medulloblastoma versus ependymoma, it really helps to look at the homogeneity of the density, and the hyperdensity on CT and restricted diffusion really suggests medulloblastoma over ependymoma. And here is the classic appearance of medulloblastoma, keeping in mind that the Wnt tumors will be more lateral in the brainstem or middle cerebellar peduncle, and the SHH tumors will be more lateral in the cerebellar hemisphere. So this more often is a group 3 or group 4, but can be seen with any of them. So we see that there is this slightly, expansile, a bit heterogeneous tumor. On T2, it has a little bit of T2 hypointensity, which may indicate increased cellularity. There is, for this one, really not much of any enhancement, maybe just a very little bit in here. The key is there's restricted diffusion. This is a highly cellular tumor. Here we have on a sagittal T2 weighted image. You can see that area of T2 relative hypointensity, indicating increased cellularity. And this is a medulloblastoma. So other highly cellular tumors include lymphoma. There's primary CNS lymphoma, which often occurs in immunodeficient patients with AIDS or after organ transplantation, with Scott-Aldrich syndrome, Sjogren's syndrome, prolonged immunosuppressive therapy. It occurs in 6% of AIDS patients. It's usually supratentorial. It can occur in the deep gray matter or periventricular white matter. It coats the ventricles and spreads across the corpus callosum. Now, in immunosuppressed patients, it can be ring enhancing, and it can be difficult to differentiate this from toxoplasmosis, which also occurs in immunosuppressed patients or immunodeficient patients. Toxoplasmosis, however, doesn't usually abut the ependymal surface. Here we have a very nice chart. Actually, I'm having trouble seeing the top of it, but we have this differentiation of toxoplasmosis and go back. This differentiation of toxoplasmosis and lymphoma. So lymphoma tends to be hyperdense on non-enhanced CT because it's highly cellular, whereas toxoplasmosis does not. It can be iso-intense, that relative hypointensity on T2-weighted images because of increased cellularity, whereas toxoplasmosis tends to be all hyperintense. Periventricular location is more typical for lymphoma. Subependymal involvement is more typical for lymphoma. Lymphoma will be positive on thallium 201 SPECT, whereas toxoplasmosis will be negative. There can be relatively increased CBV on perfusion imaging, whereas not with toxoplasmosis. Secondary lymphoma will involve the leptomeninges and CSF. It is rarely detectable in the CSF. There can be hydrocephalus. You can have supratentorial parenchymal extension. It can be multifocal with dense enhancement, but you can also see ring enhancement, and it often occurs in non-Hodgkin lymphoma. It will be 50% T2 iso-intense to hypointense because it is highly cellular. It can be heterogeneous. There can be marked and homogeneous enhancement in 90% of non-AIDS cases, but steroids will suppress enhancement. There will be ring enhancement in immunodeficient patients. It will have a lower ADC value than GBM. It will have increased choline to creatinine in MR spectroscopy. And compared to high-grade astrocytomas, the relative cerebral blood volume will be a little bit elevated, but not as much as high-grade astrocytomas. So here we have a CT. You can see this hyperdensity, this mass involving the fornix and anterior third ventricle, and then also here in the basal ganglia. Notice how avidly it enhances. It has a slightly dirty appearance with edema around it. It restricts diffusion. This is lymphoma. And that is it. So what questions do we have? Let's see if I can see questions. I don't think I can see the questions.
Sure, Virginia. I think there are some questions. Let's look at them. And thank you so much for the excellent talk. So,
thank you.
So we have a question from Dr. Fatima Ali Omar. She's a radiology resident at Muhas in Tanzania. And the question is, for patients with GBM on treatment, what are the important findings you should report in the follow-up MRI?
So it is so hard to tell the difference between progression of disease and treatment-related disease. So increase in enhancement is important, especially if somebody is on bevacizumab or Avastin. So that can indicate, if they are on that medication, that can be a very poor prognostic sign. If there's increasing mass effect, we want to report that. One tool that we have that can help us to differentiate between progression of disease and treatment effects, such as pseudoprogression, is our MR perfusion imaging. If there is increased relative cerebral blood volume, that can indicate that there is progression of disease, true viable neoplasm rather than pseudoprogression. But you really want to report the increase in enhancement, mass effect, and what the flare signal is around it. Is that increased flare signal around the tumor expanding into other areas, going a little bit more anterior or posterior or laterally than it was before? And really, you have to follow these over time. The only way to really tell for sure is to do a biopsy. And, you really want to limit doing that for patients. So it is a conundrum. I'm hoping really that machine learning may give us a less invasive answer for how to differentiate between these things. Perfusion imaging does tend to be 80 to 90% accurate for helping us to make that differentiation. But in truth, you have to follow it over time. If a patient is doing really well, even if you have a little bit of increased relative cerebral blood volume on imaging, the oncologist may decide to watch it to see, because it is a really big deal, of course, to change someone's treatment. And so they may get a short-term interval follow-up. Like you could say in 4 weeks, for example, you could do another follow-up to see if it gets better. Another thing to keep in mind is that until about 4 weeks have passed after the completion of radiation therapy, you really should not be coming down hard on whether something is progressive disease or a treatment effect. So it's good to give patients about 4 weeks for that tumor's inflammation from the radiation therapy to subside before trying to make that determination.
Perfect. Thanks so much. The next question is from Dr. Hana Larasati from Hana, Indonesia. The question is, what is your opinion about ADC values in the evaluation of brain tumors, especially in terms of its variability across different MRI platforms?
Oh, yes. So that is a really big hot topic in neuroradiology now, the lack of standardization. But I would say in general, when you see low ADC, it makes you think that there is something wrong. So for example, for a glioblastoma, after it's been treated, especially if somebody is on Avastin, and I see that low ADC area increasing over time, it makes me worry that that is progressive disease. Now, studies have shown that that could indicate a kind of necrosis, like a coagulative necrosis, or it could indicate a highly cellular tumor that is proliferating. But you're right, it is difficult to come up with a number because every site will have a slightly different way of doing this. And I think that is one of our goals that we should have in neuroradiology, is how to standardize how we do these exams so that we really can correlate one institution's imaging with another institution's imaging and follow-up. It is a problem. I agree.
Next question is from Dr. Dave Yusum. Hi, Dave. The question is, do you do qualitative or quantitative analysis of your MR perfusion studies? If quantitative, what software? Compare with the slide, and the same with ADC values, question mark, qualitative or quantitative, yeah.
So at my institution, we do quantitative imaging. We are using OLIA software, and we really like it. We tend to depend more on the DSC perfusion, and we are investigating the DCE perfusion, but I don't think that we really feel like we trust it as of yet. It's very interesting. I'm hoping that we will come to a good place of agreeing what values are abnormal and looking at the DCE perfusion, but we depend more on DSC, and we do quantitative, and we follow it over time so that we try to sample the same area with an ROI on progressive scans to make sure that we see that the trend is increasing or decreasing. As I believe Rajan Jain described it, I can't remember if it was ASNR or RSNA, he gave a wonderful talk about perfusion. And that was one of the points that I think is really important to remember, is you have to look at the trajectory of what's happening with the tumor. So in terms of ADC, I'm hoping to get my group more interested in looking quantitatively at ADC, but so far we are really looking at ADC qualitatively. But it would be better to have, as I said in the last question, to have a standardized way of doing these things across institutions so that we really can, especially if a patient moves from one part of the country to another or to another part of the world, that there is a way to follow things over time that can be consistent.
Thank you, Virginia, and thanks, Dave, for the excellent question. We have Dr. Ivan Rukundo joining us from Tanzania. He had a question. Ivan, do you want to go ahead? And Ivan Rukundo is also from Rwanda in the first radiology residency program in Rwanda. Ivan, do you want, I don't know, let me see if I can unmute you. You can go ahead right now.
Yeah, thank you so much. This was a really excellent presentation. My name is Ivan Rukundo, and I'm actually talking from Rwanda. I'm a Rwandan, and I'm doing my fellowship in interventional radiology from Tanzania. My question actually was asked by Fatma somehow, and my question was on patients who are on chemotherapy, or patients who are on radiation therapy and imaging post-radiation. And I think that was answered. I got my answer from what you answered to Fatma.
Okay, thank you.
Okay, great. Thank you.
Thank you so much, Ivan. And this is the first interventional radiology program in Tanzania. So thank you so much, Ivan, for your very good question. All right.
Oh, that's so impressive.
Yes, and this is the University of Rwanda also started their first radiology residency program in the country a few years back, and which is serving the whole country, which is very impressive. And the residents have joined us today, so very nice. We have a question from Dr. Patrick Nyongobo, who said, thank you for the nice talk. How do you distinguish GBM from a single metastatic focus on imaging?
Oh, that is very hard. I think usually we are giving a differential. If you see like nearby satellite lesions, that might lend you more toward a GBM diagnosis. But if they are, multiple lesions that are farther apart, that looks more like metastases. But there's a huge overlap in the imaging appearance, and sometimes the only way to tell is to biopsy it. So I don't feel like we at Northwestern have a really great way to differentiate. So I think you have to give a differential, unfortunately. And as one of my old attendings used to say, tissue is the issue. Maybe someday we'll have a machine learning algorithm that will be able to help us to make that differentiation. But right now it's very difficult.
Yeah, I agree. And then we have some nice comments here. I'm just going to read them out. We have a comment from Dr. Omalo Atalabi, who says, fantastic lecture, just to appreciate Dr. Hill and to say that I would have to travel from Nigeria to Chicago to listen to the summary lecture. So this is very good that we can do this online right now. Thanks so much. And he's asking for the link for the lecture. So for everyone, we'll be uploading this on the Health for the World Academy and the YouTube channel, and it will be available within 24 hours. So you can check it out there. So in case you have missed out some portions of the lecture, you can check it out there. We also have a comment from Dr. Daviuson, who said, nice overall update. Dr. Fatima says, thank you for the lecture. Dr. Muwanima Shomita says, this was very excellent. We see brain tumors most often in our working stations. This is very helpful. And then there's one more question by Dr. Daviuson, who says, has there been any reproducible success in identifying alpha ketoglutarate MRS to identify IDH?
I think that there have been some successes. We have not done that as much at Northwestern, so I don't have a huge amount of experience with it.
Yeah, all right, very good. So lots of good presentations from radiologists from different parts of the world. So thank you so much, and I really appreciate you doing this for us, Virginia. This was a very excellent and informative talk, and thanks for answering the questions so well. And thank you for all the our excellent radiologists who have attended this talk today. I hope everyone has a very wonderful day. And thank you, Ivan, for asking the question and coming as a panelist. Thanks, Virginia.
Yes. Thank you very much for the opportunity. It was a lot of fun. Have a wonderful day.
Thank you. Take care. Bye-bye.
Thanks, you too.